Okay, ma'am. We are on live, ma'am, and we are starting the session.
Dr. Stalin, we can
Yeah,
start now.
yeah. So, ma'am, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is antenatal care during COVID pandemic. I welcome all the participants. I request them to post their queries, if any, in the chat box, so that we can have a short Q&A session at the end of this presentation. And now we have our invited speaker for the day, Dr. Abba Sharma, ma'am. Madam has done her MBBS and madam is currently practicing in Apex Hospital, New Delhi. I welcome you, ma'am. Ma'am, I'm handing session to you for
Thank you.
further proceedings, ma'am. Now you can start your presentation.
Okay, so today we are going to discuss about antenatal care during COVID pandemic. A lot of us know about how to take the care of the patient, but it's very important that we should recollect all the things. So antenatal care during pregnancy. Standard recommendations for antenatal care during COVID pandemic. So there are so many ICMR, ICOG, Lancet, and Royal College of Obstetrics, World Health Organization, WHO, FOGSI. They are,
yeah, ma'am. Sorry for the interruption, ma'am. Slides are not moving, ma'am.
They're not moving.
It's not moving, ma'am.
It's moving from my side. That's why I can open and you can share. Can you share the slides?
Yeah, Stavan, whether the slides are moving or the problem is with my side.
Slides are on first slide only.
Yeah, first slide only.
It's the first slide. Yeah, they are moving from my side. I have no problem.
Okay, ma'am. Just can you go to the second slide, ma'am?
Yeah, sure. This is the second slide.
No, ma'am. It's not moving, ma'am.
Okay. Yeah.
Ma'am, if you can please click on this slide, ma'am.
I can see the slides, but they can't see it. They're saying it's not moving. This is the first slide.
Yeah, ma'am. Now it's the first slide, ma'am.
Second?
No, ma'am. It's not moving.
No.
No.
Just a minute.
Now it's moving, ma'am.
Now it's moving.
Yes, ma'am. Yeah, ma'am. Now it's clear, ma'am. Ma'am, if possible, make it in a slideshow mode, ma'am. Full screen mode.
Are they moving now?
Yeah, ma'am. Ma'am, go for the
yes,
third slide.
We can. Yes, ma'am. You can go now.
Yeah. The second slide, the Lancet College of Obstetric and Gynecology, ICOG, ICMR, and FOGSI, WHO. Effect of COVID-19 on pregnancy. Pregnant women are not at increased risk. Okay, so they are at the same risk as the other people. Do not appear more likely to contract the infection than the general population. Pregnancy itself alters the body's immune system and responds to viral infections and can have same symptoms of COVID-19. Increased risk of complications. Pregnant women with conditions like heart disease, diabetes, hypertension, and asthma, immunocompromised disease like HIV, they are at the highest risk. Effect of COVID-19 on mental health in pregnancy. Due to lockdown and isolation situation, perinatal anxiety and depression, domestic violence may increase. Hence, pregnant women requires additional mental health support. Effect of COVID-19 on fetus. No data suggesting an increased risk of miscarriages on early pregnancy loss. No evidence of teratogenicity. Currently not an indication for medical termination of pregnancy. No change in antenatal care, mode of delivery or post-natal. No evidence of COVID transmission from mother to baby, antenatally or intrapartum or during breastfeeding. No recorded cases of vaginal secretions being tested positive for COVID-19 for pregnant women. So there are very less chances of getting it transmitted from mother to fetus.
Ma'am, again the slides are not moving, ma'am. It's standing still, ma'am.
Just a minute.
Yeah.
Jay, they're not moving again. I think there is some problem. So it's better if you can share the slides.
Okay, ma'am. Yeah, ma'am, you can just click down arrow and you can carry on, ma'am. You can. Stavan, do you have the slides with you?
No, I don't have the slides.
Okay. 1 second, let me check with Nishan.
Okay.
Ma'am, you can click on the slide and you can just carry on, ma'am.
Okay.
Now you are in the 6th slide. Yeah, ma'am. Now it's moving, ma'am. Yes, ma'am.
General guidelines for obstetric healthcare providers. Obs-gynae should contact their local or state health department for guidance on testing persons under investigation and should follow the national protocol. Should promptly notify infection control personnel at their facility of the anticipated arrival of pregnant patient who has confirmed COVID-19 or in PUI so that infection control measures can be kept in place. Should maximize the use of telehealth across as many as aspects of prenatal care. Registry for all women in pregnancy admitted to with confirmed COVID-19 infection should be maintained. Maternal and neonatal records with outcome details should be preserved for analysis in future. Each facility should consider their appropriate space and staffing needs to prevent transmission of the virus that causes COVID-19. General guidelines for obstetric healthcare providers. Pregnant women should be advised to increase their social distancing to reduce risk of infection and practice hand hygiene. Intrapartum services should be provided in a way that is safe, with reference to minimum staffing requirements and the ability to provide emergency obstetric, anesthetic, and neonatal care where indicated. A single asymptomatic birth partner should be permitted to stay with the woman at a minimum through pregnancy at birth. Visitors should be instructed to wear appropriate PPE, including gown, gloves, face masks, and eye protection. Women should be met at the maternity unit entrance by staff wearing appropriate PPE kit and be provided with surgical face mask. Face mask should not be removed until the woman is isolated in a suitable room. Staff providing care should take personal protective equipment precautions as per national guidelines. Obstetric management considerations. Medical history, this is very important for all pregnant women. Obtain the following information: a detailed travel history, a history of exposure to people with symptoms of COVID-19, symptoms of COVID-19 coming from hotspot area, and immunocompromised condition. These are all the information the patient will provide. Obstetric management considerations. Information to be shared with pregnant women. These are the information to be shared. If you infect with COVID-19, you are still most likely to have no symptoms or a mild illness from which you will make a full recovery. If you develop more severe symptoms or your recovery is delayed, this may be a sign that you are developing a more significant chest infection that requires enhanced care. You should contact your maternity care team immediately. There may be need to reduce the number of antenatal visits you have. However, do not reduce your number of visits without agreeing first with your maternity team. Clinical presentation of COVID infection in pregnancy. Clinical presentation remains same as the general population. Mean incubation period 5 to 7 days. Fever more than 38 degrees or any one or more of the following: dry cough, sore throat, difficulty breathing or soreness of breath, gastrointestinal symptoms. Laboratory testing to diagnose remains same as of general population. Investigations. There will be leukopenia, lymphocytopenia, mild thrombocytopenia, mild elevation of liver enzymes, other acute infection markers, radio imaging with abdominal shield should be done. Do's and don'ts for obstetric care providers in COVID-19 pandemic. If a woman meets criteria of COVID-19 testing, she should be tested. Until test results are available, she should be treated as though she is confirmed COVID-19. Do not delay obstetric management in order to test the COVID-19. Elective procedures like induction of labor are not strictly necessary. Routine growth scans, not for a strict guideline-based indication, and routine investigations should be reduced to minimum. Decontaminated ultrasound equipment should be used. Classification of COVID patients. COVID-19 patient, if they are asymptomatic, you cannot make it out. There's mild, that there is upper respiratory symptoms or fever without shortness of breath, hypoxia. There will be mild cases. Moderate, anyone of the respiratory rate more than 24 per minute, SpO2 less than 94% on room air. They are the moderate cases. And then severe. Any case of respiratory rate more than 30 per minute, SpO2 less than 90 on room air. So they are the severe cases. COVID-19 patients at a triage. Assessment of the patient symptoms and signs, including all vitals, inquire about comorbidities of the patient, ongoing medications, and treatment. SpO2 more than 94 with room air. So there is classification of, they need home isolation. They are the A, B, and C, asymptomatic, mild symptoms, and comorbidities. And SpO2 less than 94% of room air, D and E. So they should be admitted in wards and STU. And sepsis, septicemic shock. This is the F. They need an ICU care. Case scenario discussion, case 1. 32-year-old G2P1L1 with 32 weeks of gestation. Tested COVID positive. She is asymptomatic. Pulse rate 84 per minute, temperature 98, BP 110/70 mmHg, and pulse rate 16 per minute. SpO2 98 on room air. CVS and RS with normal limits. Parabdomen uterus 32 week, relaxed with cephalic presentation. Nycor is normal. Will you admit her or recommended home isolation? So now this is the asymptomatic case in third trimester. Recommendation is home isolation as a home monitor. Points to consider: if such patients need to be hospitalized, if she is with comorbidities like diabetes, hypertension, anemia, or will not be able to manage at home, whether she will be able to take care of herself, if she have enough space at home, the family support is required here. If oximeter shows less than, saturation is less than 95. Walk test or stress test if patient feels breathless. Advice on self-monitoring while on home isolation. Prepare 3 times a day chart. Note down if any fresh symptoms are observed, how she is feeling while breathing. Is it same, better, or worse? Check the body temperature by thermometer. Check the SpO2 rate by oximeter. If less, self-proning position can be performed. Check the heart rate if it is fast or slow. Advice on diet, because loss of appetite and weight loss are common signs in COVID patients. There is no specific diet guidelines for COVID patients. So she can have whatever she wants, but she should have good diet. Hydration is important. Plenty of fluid intake needed. In SpO2 is less than 94 and have a persistent fever for 5 days, even after taking antipyretics, difficulty in breathing, diarrhea more than 4 times, immediately report to monitoring physician. Danger signs of COVID-19 should be explained to the pregnant woman. Improve lung oxygenation. This is a prone position, which is very, very important in COVID, and especially at the time of Delta, this was very much important. We used to tell the patient to lie down in supine position. So here in first patient is lying in supine position. In second one, she has switched to lying on right side for 30 minutes to 2 hours. Switch to 30 minutes to 2 hours for sitting up. That's the upright position. And switching to lying on your left side for 30 minutes. And then again switch to semi-prone position for 30 minutes and then proning position for 30 minutes to 2 hours. This cycle can be repeated. Eligibility for home isolation, home care applicable to pregnant. The person shall be clinically assigned as asymptomatic mild case through telephonic triage by the health staff, medical staff, physicians. Such cases should have the requisite facility at their residence for self-isolation and to quarantine the family contacts. A caregiver should be available to provide care on 24/7 basis. A regular communication risk between the caregiver at hospital is a prerequisite for the entire duration of home isolation, home care. The person should provide a signed undertaking for self-isolation, home care, and follow guidelines of home isolation or home care. The person shall agree to monitor her health and regularly inform their health issues to the telemonitoring team or medical. Home isolation care should not be applicable for pregnant women 2 weeks before the ED. Tips for managing COVID-19. Coronavirus at home for adults. If you have COVID-19 symptoms, consult with a doctor, get tested. Check oxygen level, that is by pulse oximeter, you can check it home. Wear a mask, open the windows for ventilation, stay isolated, stay hydrated, and fever medicines, paracetamol and all can be taken. If oxygen level is 92 or more, fever medicine and stay hydrated, lie on your stomach, that is the prone position I told you earlier. Inhale budesonide steroid 2 puffs twice a day until symptoms improve. If oxygen level is less than 92%, consult with a doctor, then you need a hospital care. The following are proven treatments recommended under medical supervision. Lie on your stomach, use oxygen, monitor oxygen level. Dexamethasone 6 mg orally or IV once daily for 5 to 10 days. If dexamethasone unavailable, one of these: hydrocortisone 50 mg orally, methylprednisolone, prednisone 40 mg orally once daily 5 to 10 days. Steroid can be stopped 5 days if oxygen is no longer needed. Remdesivir may shorten the duration of symptoms but does not decrease the risk of death from COVID-19. Should only be given with physician supervision. Topisolib should only be given with a physician supervision, and treatments that are not routinely advised, ivermectin, hydrochloroquine, which were used to be effective earlier, plasma and vitamin C, D, zinc, they have no effect. Home quarantine, red flag signs. Clinical condition check. Symptom condition, difficulty in breathing, no. And SpO2 is more than 94%. Respiratory rate is less than 24. And now these are the low risk cases. Now high risk cases, they have difficulty in breathing, SpO2 less than 94%, and respiratory rate is more than 30%. Cough is tolerable in low risk patient, is severe in high risk. Loose motions less than 4 times a day and more than 4 times a day in high risk cases. Fever is very mild in low risk cases and 101, more than 101 for 4 days. Comorbidities, there are no comorbidities in low risk patients, and there are comorbidities in high risk patients. Case scenario 2. 24-year-old G2P1L1 with 28 weeks of gestation presented with fever, myalgia, cough for 3 days duration, eyelid symptoms, tested COVID positive, referred Other hospital on examination temperature is 100.4 degrees Fahrenheit, pulse rate 106, and BP is 120 by 70. O2 saturation is 96%, it's room air. CVS RS within normal limit. Uterus 28 week, like a normal cephalic presentation. Now, will you admit her? So, this again comes to mild category. During second wave, such patients are advised to be at home isolation. If develop more symptoms, then only admit. Home isolation for asymptomatic and mild, no investigation required. Admit patients with comorbidities. If without comorbidities, investigation is done at day 5 to 7 if patient does not recover. Management antibiotics like azithromycin, doxycycline, and medication like ivermectin is contraindicated. Oxygen concentrator, oxygen cylinder is not required for asymptomatic or mild cases where patient can have tolerable bleeding. Steroids should not be used in pregnant women as first line of treatment. In mild or asymptomatic cases, the role of chemoprophylaxis in asymptomatic and mild cases, HCQ and steroid should not be used, not a good practice. Unfortunately, there is no separate kit for pregnant women. Asymptomatic and mild patient, no need to hallmarkers test required. It is only happening in India. No other country do this test because of they give maximum false value in the patient. HCQ was prescribed in first wave. WHO said there is no value of this drug during second wave. Case scenario 3. 28-year-old primary with 38 week plus 4 days. Presented with fever, myalgia, cough of 5 days duration, was tested COVID positive 2 days back. On examination, temperature 99.4 degrees Fahrenheit, pulse rate 100 per minute, respiration rate 26, BP 100 by 70. O2 saturation 94% in room air. Respiratory system bilateral basal crepitations were present. CVS was normal. Obstetric examination showed term pregnancy, single live fetus with cephalic presentation, not engaged with slight decreased air volume. An emergency LSCS was done on the same day in view of non-reassuring anesthesia. In post of day 1 and day 2, saturation dropped to 88%. With 8 liters of O2 with face mask, SpO2 was 90%. Was switched over to NRBM and SpO2 raised to 98%. She was shifted to HTA. Now, this case comes under moderate category. If less than 94 needs treatment, inflammatory markers play role here. 6-minute walk, if SpO2 drops, patient needs to be admitted. After repeated PCR test negative, CT scan can be done to check if there is any thyroid or lung damage occurred. Course of illness in COVID-19, survivability, that is shown by the purple line, viral load, and inflammation. When do we test for COVID-19 in pregnant women? Any guideline? Some special criteria for testing with regards to pregnancy. All symptomatic individuals who have undertaken international travel in last 40 years, they should be tested. All symptomatic contacts of laboratory confirmed cases. All symptomatic healthcare workers. All patients with severe acute respiratory illness. Fever and cough or soreness of breath. Pregnant women residing in clusters containing contaminant areas or in large migration gatherings, evacuee center from hotspot districts presenting in labor or likely to deliver in next 5 days should be tested even if asymptomatic. Symptomatic individuals with influenza-like illness from hotspots should be tested for RT-PCR within 7 days or serology after 7 days. Asymptomatic individuals should be tested between 5 to 14 days of exposure to a known contact. There is no recommendation for testing every pregnant woman. What are the tests done for diagnosis of COVID-19 in pregnancy? Diagnostic tests for COVID-19, gold standard RT-PCR and CBNet, TrueNet, RAT, antibody testing for serosurveillance. Facts related to COVID testing are TrueNet validated by ICMR, CBNet to be done only in NABL accredited labs that takes 45 minutes. Abbott ID now takes 15 minutes. False positive and false negatives. TrueNet and RAT test show low sensitivity with fast reports. Rapid antigen test kit, self-testing, ICMR approved sensitivity is 60%. RT-PCR 70% sensitivity. It can be repeated for interpretation. Day 0 up to week times. Antibody produced, RT-PCR done in second week. False negative report. Target test may be negative due to new variant. Antenatal care ICMR guidelines. Optimize antenatal visits. That is 12 week, 20, 28, and 36. So we should cut short the antenatal visits. If asymptomatic visits 7 days after the start of symptoms to maintain DMFC. If asymptomatic, defer to 14 days. Yes, own transport, call 108, but inform about your COVID status. Advise USG after resolution of symptoms unless it is emergency. Pre-book visits to avoid waiting. Level 2 protection for doctors and SMS. Surgical mask for the patient and organized clinic to prevent transmission. Disinfect fomites and fumigate the clinic at the end of the day. Telemedicine as appropriate. Precaution and guidelines for ultrasound scanning of pregnant patient in COVID situation. Due to prolonged examination time, small room size and proximity transmission, risk is high with obstetric ultrasound. Minimum number of probes should be used. In a hospitalized woman, besides ultrasound is preferable. Ultrasound machine and fomites should be disinfected. The probe should be washed, dried, and disinfected. At the end of the day, the room should be disinfected or fumigated. Ultrasound represents a high risk of isolation situation of coronavirus transmission. The virus can survive on inanimate surface, which is an ultrasound machine for 48 to 96 hours. So the ultrasound is risky in pregnancy. Importance of video consultation and teleconsultation, telemedicine. In view of restrictions on patients because of COVID-19 pandemic, face-to-face consultations are difficult. Telemedicine plays an important role to reduce hospital visits for non-emergency situations and to identify emergency cases without delay during this lockdown phase. Telemedicine has provided us the opportunity to manage women health problems and pregnancy concerns during this pandemic COVID-19, except a few instances where face-to-face consultation or hospital visit is must. WHO declared COVID-19 as pandemic on March 11, 2020. Many hospitals and practices had to cancel routine outpatient visits, and out of necessity, most of the practices have been encouraged to use telemedicine and video consultation as a method of continuity of care. Importance of video consultation and teleconsultation. Pregnant women are the vulnerable population, has guidelines to support through video consultation will go a long way in reducing complications and timely intervention during the pandemic. Government of India and Medical Council of India released their new guidelines for use of telemedicine during this pandemic, which was boon for both patients and doctors. Women's health, especially pregnant women, can utilize this facility and avoid contracting the infection. For gynecological disorders, if no emergency, can also be managed through this facility from the comfort of their homes. Gynecologists and obstetricians can interact with the patients, gather complete history, educate them and regarding the warning sign in pregnancy, and give advice and instruction them to come for physical consultation if needed. Telemedicine in India can go a long way in future, at least for non-emergencies and low-risk treatment. Also, not only COVID-19, but this can also help to reduce transmission of many diseases and reduce overall disease burden on healthcare. The described trials pathway for telemedicine allow for necessary urgent emergent obstetric and gynecologic care and helps in minimizing the exposure that would be associated with standard consultations. Recommended teleconsultation for this period, confirmation of pregnancy for second and third trimester, routine NCPS. So just stay home. New obstetric consult recommended face-to-face consultation for high-risk cases, uncontrolled diabetes, gestation hypertension. Advice to visit emergency to both groups. If pain, bleeding, less movements, watery discharge, vaginal miscarriage, antepartum hemorrhage, warning sign for preeclampsia, preterm labor. That should be explained to the patient. Now, new gynecology consult, emergency, no emergency, yes, there is no emergency. Recommended teleconsultation for conditions such as urinary tract infection, vaginal itching, dryness, irritation, AUB, it can be managed medically, fibroids, PCOS, endometriosis, mild pelvic inflammation. During teleconsultation, doctor decides if patient needs face-to-face consultation or not. Recommended face-to-face consultation, suspected torsion ectopic pregnancy, hemoperitoneum, acute pelvic inflammatory disease, heavy vaginal bleeding, and others. Manage conservatively if possible, else surgery will be required. Points to remember for telemedicine. Consent is mandatory. General considerations. Maintain confidentially medical record with reports, laboratory investigations, and prescription. Patient can be charged for consultation. Schedule prescribing drug, narcotics, or psychotropic substances cannot be prescribed. Patient and doctor both should understand that telemedicine is not a substitute for physical examination. If required, patient should be called for face-to-face consultation immediately. Healthy lifestyle education, assessment of our understanding of self-care, education regarding fetal movements and warning signs. Pregnant patient is second and third trimester should be taught about daily fetal movement count, signs of labor, and identifying leaking. Along with general gynecological and obstetric advice, they should be taught about COVID-19 situation and importance of hand washing, sneezing equipment, social distancing should be explained. Points to remember for telemedicine in new cases. Any first consult or follow-up more than 6 months, video consultation is preferred. New prescription issued should have all the information, name, age, complaints, clearly written medicines, doctor signature, number, and medicine should be explained well with the time of intake as well as before or after food. Don't put off necessary medical appointments. Life has to continue even where COVID-19 is spreading. Here is how to stay safe. Reduce your risk. Call to check if phone or telemedicine consultation if possible and appropriate. If not, schedule your appointment in advance. Many healthcare services can be delivered via telemedicine during and after pregnancy. Services delivered after pregnancy, postpartum. Services delivered, this will be shown in blue. Services delivered during the pregnancy, prenatal care, that is in green, and services delivered during and after pregnancy, prenatal and postpartum. At home monitoring, weight, blood pressure, fetal heart rate, blood sugar, etc. Consultation with specialists, maternal fetal medicine, genetic counselors. Virtual prenatal care visits. Then online communication with providers, mental health care, virtual postpartum visits, that is the after pregnancy, and lactational support. Special situation requiring face-to-face consultation. Pregnant patient with missed abortion with labor pains, PROM, that is premature rupture of membrane, gestation hypertension, if uncontrolled, antepartum hemorrhage, ectopic pregnancy, and molar pregnancy. They need face-to-face consultation. For gynecological patients with heavy menstrual bleeding, not responding to medication, suspected ovarian torsion, acute pelvic memory disease, and others. How to wear a mask. Clean your hands before you put your mask on, as well as before and after you take it off. And after you touch it at any time, make sure it covers both your nose, mouth, and chin. When you take off a mask, store it in a clean plastic bag and every day either wash it if it's a fabric mask or dispose of the medical mask in a trash bin. Don't use masks with valves. I think surgical masks are the best thing. Pregnant women should take care some precautions to avoid COVID-19 infection as other people who can help protect yourself by. Washing your hands frequently with an alcohol-based hand rub or soap and water. Keeping space between yourself and others and avoiding crowded spaces. Wear a non-medical fabric mask where it is not possible to keep sufficient physical distance between yourself and others. Avoid touching your nose, eyes, and mouth. Practicing respiratory hygiene. This means covering your mouth and nose with your bend elbow tissues when you cough or sneeze. Then dispose of the used tissue immediately. If you have fever, cough, or difficulty breathing, seek medical care early. Call before going to a health facility and follow the directions if your local health authority. Follow directions of your local health authority. Pregnant women who have recently delivered should attend their routine care appointments according to local policies and following adopted measures to reduce possible transmission of the virus. Can COVID-19 be passed from a woman to her unborn or newborn baby? We still do not know if a pregnant woman with COVID-19 can pass a virus to her fetus or baby during pregnancy or delivery. To date, the active virus has not been found in samples of fluid around the baby or in the womb or breast. Do pregnant women with suspected or confirmed COVID-19 need to be birthed by cesarean section? No. Cesarean section should only be performed when medically justified. The mode of birth should be individualized to based on women's preferences alongside obstetric indication. Can I touch and hold my newborn baby if I have COVID-19? Mother is asking this. Yes. Close contact and early exclusive breastfeeding helps a baby to thrive. You should be supported to breastfeed safely with good respiratory hygiene. Hold your newborn skin to skin and share a room with your baby. You should wash your hands before and after touching your baby and keep all surfaces clean. Mothers with symptoms of COVID-19 are advised to wear a medical mask during any contact with the baby. Rules for pregnant women. Monitor temperature, pulse, BP, O2 saturation twice daily. Check O2 saturation. Isolate and hydrate well. Take cough syrups as well and paracetamol. Keep in touch with HCP. Inform if red flag signs present. Good food, yoga, pranayam, meditation, breathing exercises. Have positive attitude. Don't for pregnant women. Do not give COVID profile test done. Do not take antivirus. Do not take ivermectin. Do not take antibiotics unless advised by your doctor. Do not take steroids. Do not repeat RT-PCR. Do not watch news. That is very important. Intervention in various scenarios. Pregnant woman having flu symptoms tested negative. If no obstetric intervention required, she shall be home quarantined till the symptoms resolve. Referral for antenatal ultrasound services for fetal growth surveillance recommended after 14 days after resolution of acute illness. For women self-quarantined because of some household has possible symptoms of COVID-19, appointment should be deferred for 14 days for antenatal visit if there is no emergency. For women having symptoms, appointments can be deferred until 7 days after the start of symptoms, unless symptoms aside from persistent cough become severe. If previously a pregnant woman tested negative for COVID-19 and symptoms reappear, she should be treated as COVID suspect and should be tested for COVID-19 again. If pregnant woman who has a routine appointment delayed for more than 3 weeks should be contacted by ANM and ASHA worker. Advisory for antenatal woman during COVID situation. Disinfection of surfaces to reduce fomites related spray. For women working outside the house, it is preferable to take work from home, keeping a distance for at least 1 meter in various necessary interactions and activities. Avoid non-essential travel. If travel is undertaken, it is preferable to use a private vehicle. Avoid gatherings and functions to celebrate the 7-month milestone, which is a common cultural practice. Minimize visitors from coming to meet the mother and newborn after the delivery. Use of drug during pregnancy in COVID setting. Use a low-dose aspirin or other NSAID. No change in recommendation. Use of NSAID like ibuprofen is not required. However, due to importance of low-dose aspirin in preeclampsia prevention, low-dose aspirin should continue to be offered to pregnant and postpartum women as medically indicated. Use of magnesium for preeclampsia, seizure, and prophylaxis. The risk of eclampsia should be balanced against the risk of respiratory depression in the setting of SARS-CoV-2. The single 4-gram bolus dose of magnesium sulfate may be served as an alternative to usual dosing of setting of mild respiratory. Use of antenatal corticosteroids before 7 weeks of gestation, no change in recommendation. Prophylactic drugs contraindicated in a COVID hospital confirmed. Yet decision to be individualized. General guidelines. All women, despite a pandemic, have a right to have safe and positive childbirth experience. Informed consent. In addition to routine consent, it would be prudent to include suspects related to COVID-19 infection for the time of pandemic. So a consent should be taken. The points that should be included are the probable chances of COVID-19 infection while in hospital. So if patient in the hospital can get the infection, and if its consequences and precaution to be taken to avoid the infection. Minimize the number of people involved in any procedure. A single asymptomatic birth partner can be permitted to stay with the woman at a minimum through pregnancy and birth. Standard universal precautions to prevent contact with body fluids need to be followed. Labor timing of delivery. COVID-19 infection should not dictate timing of delivery except the cases where the potential of rapid deterioration in maternal respiratory status or maternal life is at risk. For women with suspect or confirmed COVID-19, early in pregnancy who recover, no alteration to the usual timing of delivery. For women with suspect or confirmed COVID-19 in the 3rd trimester, it is reasonable to attempt the postponed delivery until they recover, provided no other medical indication arises. Titrating oxygen therapy aim to keep oxygen saturation less than 94%. Prolonged labor should be avoided. Early decision for C-section should be taken in case of prolonged labor. If a woman has sign of sepsis, investigate and treat as per guidance on sepsis in pregnancy. But also consider active COVID-19 as a cause of sepsis and investigate according to guidelines. Continuous electronic fetal monitoring in labor. Mode of birth should not be influenced by the presence of COVID-19 unless the woman's respiratory condition demands urgent delivery. Epidural analgesia should be recommended in labor to women with suspected confirmed COVID-19 to minimize the need of general anesthesia if urgent delivery is needed. Here in labor, C-section indication. COVID-19 is not an indication for C-section. Decision based on obstetric fetal or maternal indication and not COVID-19 status alone. When cesarean birth or other operation procedure is advised, it should be done after wearing teeth. An individualized decision should be made regarding the shortening of length of the second stage of labor with elective instrument birth in a symptomatic woman who is becoming exhausted or hypoxic. Delayed cord clamping. According to WHO, delayed umbilical cord clamping is highly unlikely to increase the risk of transmitting pathogens from mother to the fetus, even in the case of maternal infection. Intrapartum care. Once settled in an isolation room, a full maternal and fetal assessment should be conducted to include assessment of the severity of COVID-19 symptoms. Delivery should be preferably at tertiary care center. Maternal observations including temperature, respiratory rate and oxygen saturation. Confirmation of the onset of labor as per standard care. Electronic fetal monitoring using electrocardiograph, CTG. Hourly oxygen saturation during labor. Management of pregnant women with COVID-19 admitted to critical care. Titrate oxygen to keep saturation more than 94%. Hourly respiratory rate monitoring. Even if saturations are normal in young fit pregnant women, respiratory function should be managed by starting or increasing oxygen to avoid sudden deterioration. Radiographic investigation should be performed, especially CT chest is essential for evaluation of patient with COVID-19. Abdominal shielding can be used to protect the fetus as per normal protocols. Additional investigations, ECG, CTPA, and appropriate electrocardiogram do not assume all pyrexia is due to COVID-19 is also performed full sepsis screening. Consider bacterial infection if the white blood cell count is raised. Lymphocytes usually normal or low with COVID-19 and commence antibiotics. Apply caution with IV fluid management. Try boluses in volumes of 250 to 500 ml and then assess for fluid overload before proceeding with further fluid resuscitation. The frequency and suitability of fetal heart rate monitoring should be considered on an individual basis. If urgent delivery is indicated for fetal reasons, birth should be expedited as normal as long as the maternal condition is stable. Medical management, supportive therapy, rest, oxygen supplementation, fluid management, and nutrition. Hydroxychloroquine in a dose of 600 mg, 200 mg twice daily with meals, azithromycin for 10 days. Antibiotics if there is suspicion of secondary bacterial infection, oxygen. If there is difficulty in breathing, oxygen supplementation by nasal prongs or mask may be added. High flow nasal oxygen 4 to 6 liters per minute should be immediately administered. Non-invasive ventilation can also be used. Re-evaluation of the patient's status should be done. Indications for ICU admission. Respiratory rate more than 30 breaths per minute. Oxygen saturation less than 93 at rest. Arterial partial pressure of oxygen, PaO2 oxygen concentration less than 300 mg. Patients with more than 50% lysis progress with 24 to 48 hours in lung imaging. Quick sequential oxygen failure assessment score should be useful adjacent to deciding making for ICU management. So these all the things are required for the physician. They should take care of all this. Mother and baby contact. If separate room is not the option, permit the rooming in of the newborn with the mother. Use a curtain between mother and baby. Keep newborn more than 6 feet away from the ill mother. If mother is really ill, if no other healthy adult is present in the caregiving, mother should be put on a face mask and practice hand hygiene before each feeding or close contact with a newborn. Face mask should remain in place during contact with the newborn. Breastfeeding. During temporary separation, mothers who intend to breastfeed should be encouraged to express their breast milk to establish and maintain milk health. If possible, a dedicated breast pump should be provided. Prior to expressing breast milk, mothers should practice hand hygiene. After each pumping session, all parts that come into contact with breast milk should be thoroughly washed and the entire pump should be appropriately disinfected as per the manufacturer's instruction. This excess breast milk should be fed to the newborn by a healthy caregiver. If a mother and newborn do room in and the mother wishes to feed the breast, she should put on face mask and practice hand hygiene before each feed. Discharge counseling. Discharge for postpartum women should be followed with conditions described in the guidelines for discharge of hospitalized patients with COVID-19. Test should be negative and maternal and fetal neonatal condition should be stable. Reduce the physical visits to healthcare facility of mother and newborn unless urgent. Inform how she can communicate with their obstetric pediatric care team, especially in the case of emergency. Inform woman to return to facility in case of fever, respiratory symptoms, or any danger sign. For patients, inform woman to return to facility in case of fever, respiratory symptoms, or any danger sign. For patients who express interest in postpartum contraception, suggest all family planning options within the limitation of decreased postpartum in-person usage. Those experiencing anxiety regarding the COVID-19 pandemic are at an increased risk of intimate partner violence. Offer mental health or social work services or referrals to provide additional resources. Stable neonates exposed to COVID-19 are being roomed in where their mothers may be discharged together at the time of mother's discharge. Discharge policy for COVID-19 patients. Revise discharge policy for COVID-19, confirm COVID-19 cases. Very mild, pre-symptomatic. Discharge after 10 days of symptoms onset and no fever for 3 days. Moderate, fever resolved within 3 days and oxygen saturation maintained without support. Discharge after 10 days of symptom onset, absence of fever without antipyretics, resolution of breathlessness, no oxygen required. No RT-PCR test required before the discharge. Symptoms not resolved and demand of oxygen therapy continues. Discharge only after resolution of clinical symptoms, ability to maintain oxygen saturation for 3 consecutive days. Now we come to severe cases. Discharge only after clinical recovery. Patient tested negative. In this case, there is RT-PCR required. General advice for obstetric emergency gynecology theatre. Elective obstetric procedure, cervical or cesarean should be scheduled to the end of the operation. Non-elective procedures should be carried out in a second obstetric theatre where available, allowing time to full post-operative theatre cleanup as per National Health Protection Guide. The number of staff in the operating theatre should be kept to a minimum and all must wear appropriately. Advice regarding anesthesia for cesarean. Incubation of general anesthesia is an aerosol generating procedure. This significantly increases risk of transmission of coronavirus to the attending staff. Regional anesthesia is not an AGP. For the monitoring of cesarean births, where GI is planned from outset, all staff in theatre should wear full PPE, including the fitting face piece level 3 mask. The scrub team should scrub and don PPE before the GA is required. Comment. Hand hygiene. Use of alcohol-based hand sanitizers that contains 60% to 95% alcohol before and after all patient contact. Contact with potentially infectious material and before putting on and upon removal of PPE, including gloves. It can also be performed by washing with soap and water for at least 20 seconds. If hands are visibly soiled, use soap and water before returning to alcohol-based hand sanitizer. Personal protection equipment for management of suspect confirmed patients of COVID-19. Respiratory protection, tipper layered surgical mask or N95 face mask. They are needed when performing an aerosol generating procedure or in an area where units are being provided respiratory support by CPAP device ventilator. Personal protection equipment for management of suspended confirmed patient of COVID-19. Safety goggles for COVID-19. Eye protection goggles will not be usable for those using vision glasses and face shield. Personal protection equipment for management of suspected confirmed patients of COVID-19, body protection. Long sleeve water resistant complete gown, including head and shoe cover. A single piece head to toe water resistant body cover will be ideal for attending resuscitation in delivery room or OT. Hand protection, well-fitting gloves. Thank you. Thanks a lot for.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. You have covered almost all the measurements, preventive measures that has to be taken during this COVID-19 for a pregnant woman, ma'am. Thank you for the wonderful session, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I will read it for you, ma'am. Ma'am, we have only one question, ma'am. Whether these drugs like antiviral drugs like remdesivir and this lopinavir, ritonavir is safe in pregnancy, ma'am?
Actually, they should be given with lot of care, and it should be ultimately the decision of physician. If it's life saving, it can be given.
Okay, ma'am.
Otherwise, remdesivir and all, they have not much use.
Yes, ma'am.
In second wave, they said that they are useful, but actually they are not at all useful.
Ma'am, do you observe any changes in the third wave, ma'am? Like, what is your experience in the first 2 waves, and what is the current situation in?
Second wave was really dangerous. A lot of people died, and I used to get around 50 to 100 calls in a day just to get the bed in the hospital, oxygen bed. Now we are not getting any admissions. People are at home and they are recovered. This is the big difference.
Yeah, ma'am. Ma'am, in your slides, you have covered the importance of telemedicine, ma'am.
Yeah.
So how it is safe when it comes to pregnancy, ma'am? And if example, how do you manage
You can
this?
reduce the antenatal visits. This is you can have only 4 visits in spite of having 10 visits. 10 antenatal visits are recommended usually. So you can have only 4 visits. Rest of visits you can have on tele.
Okay, ma'am.
If patient is intelligent enough, then only.
Okay.
If patient is not intelligent, then you cannot say anything. Because of then you have to see the patient face.
Fine, ma'am. Ma'am, another question, managing GDM in pregnancy during this COVID situation, how to manage GDM, ma'am?
GDM actually in COVID patients, sugar levels, they are really increasing a lot.
Yes, ma'am.
To manage GDM, we have physicians and they will give us the idea. Usually we have to put them on insulin, sliding scale of insulin. Metformin is not that much useful in COVID patients.
Yes, ma'am. Ma'am,
COVID with GDM is really dangerous. They should take a good care. They should contact their physicians and get blood sugar 4-5 times a day.
Okay, ma'am.
Like before meals and after meals.
Okay, ma'am. Ma'am, we have another question, ma'am. Is there any protocol for isolation for lactating and pregnant mother, ma'am? Pregnant mother.
The mother
Whether they should be isolated separately
from other people in the family. But with the baby, it's really difficult to get isolated. The only thing is that she should maintain the hand hygiene and she should wear mask always. That is the most important. And if she is having severe COVID, then only they need isolation. And in that case, the breast milk can be taken out by the breast pump and can be fed to the baby. Otherwise, in mild cases, there is no isolation.
Okay, ma'am. Thank you, ma'am. There is no other questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
I think we can wind up now.
Yeah, ma'am. Thank you, ma'am. Thank you very much for your time and concern for being with us today, ma'am. That was a wonderful session again, ma'am. I'd also like to thank the participants for their active participation, ma'am. Thank you, everyone, ma'am. Thank you, ma'am. I'm ending the webinar.
Thanks the whole team. Thanks a lot.
Thank you, ma'am.
Ma'am, we can close, ma'am. So please, you can we can leave.
I'm closing it now.
Yes. This is our Twitter page. Here you will find all the profiles of our